basically encompasses the use of local anesthetics in the first place, and subsequently to take care of the post-operative pain, we prescribe certain drugs. So that shall be the topic for my today's discussion. That is endodontic pain control. Good evening, everyone. Myself, Dr. Nitin Kararia, and I welcome you all to this session. So let us first see what is pain control in endodontics. As I've already told you, it would be encompassing two different things. During the procedure, we would be administering ALA to the patient to manage the pulpal pain, and subsequently to take care of the preoperative or the postoperative pain, we advise certain medications. So let us see what are the different techniques for LA, what is the pathophysiology, what is the techniques, etc. related to the endodontic pain control. Firstly, we'll talk about the local anesthetics. Local anesthetics, all of you know, they are basically weak bases, okay, represented chemically as RN. And most of the local anesthetics currently in use are amide type of local anesthetics. The amide type of local anesthetics, they have the advantage, means they have got very less probability of adverse reactions. They are very well tolerated by the patients. From almost all groups of patients, we can safely administer them. So it is the weak base form, that is the uncharged molecule that crosses the plasma membrane. Some basics of the pharmacology, and then it becomes acidic charged form. After crossing the cell membrane, it comes in acidic charged form represented as RNH positive. And this acidic charged form of the local anesthetic, it binds to inner pore of some voltage gated sodium channels. VGSC stands for voltage gated sodium channels, and it blocks sodium conduction. This is the basic mechanism of action of local anesthetics, which are weak bases. So it would cross the plasma membrane in the basic uncharged form, and when it crosses, it would ionize, and it is the acidic charged form that binds to the inner pore of VGSCs. VGSC stands for voltage gated sodium channels, and blocks the sodium conduction. Now, these voltage gated sodium channels, which are present on the different tissues of the body, there are 9 subtypes of these voltage gated sodium channels. They are distributed all over the sensory nerve fibers throughout the body, from the central nervous system to the heart to the muscles, etc. These 9 subtypes of voltage gated sodium channels, they are represented as 1.1, 1.2, 1.3, so on up to 1.8, 1.9. NAV 1.1 through 1.9. What are these? These are 9 subtypes of voltage gated sodium channels which are present on the sensory nerve fibers. Now, what actually happens out of these 9 subtypes, type 1 through type 7, NAV 1.7, they are sensitive to a toxin that is called tetrodotoxin. Tetrodotoxin means they are called TTX sensitive. What is tetrodotoxin? It is a toxin that is obtained from the pufferfish. Okay, it's a marine animal, the pufferfish. From that we obtain a toxin that is called tetrodotoxin. So these 9 subtypes of sodium channels are present on the various sensory fibers. Out of them, subtypes 1 through 7, they are sensitive to tetrodotoxin. These are also sensitive to the action of commonly used local anesthetics. Okay, but these subtypes 8 and 9, which are mostly present on peripheral sensory nerves, like the nerves present in the dental pulp of patients with irreversible pulpitis. Okay, they are resistant to tetrodotoxin. They are resistant. They are not blocked by these tetrodotoxins, so they are represented as TTXR. Okay, R represents resistance. So these sodium channels are also not blocked by commonly used local anesthetics. Above, we have seen the mechanism of action of local anesthetics. Now, these subtypes 8 and 9, they are not blocked by the commonly used local anesthetics. And what actually happens, these subtypes 8 and 9s, they are increased in number in teeth with symptomatic irreversible pulpitis. In teeth with symptomatic irreversible pulpitis. What is symptomatic irreversible pulpitis? Patient is complaining of spontaneous pain in a tooth. Okay. So what would happen in such cases? The sensory nerve fibers present in the dental pulp, they would be having a conspicuous amount of these tetrodotoxin resistant sodium channels. And such teeth which are having symptomatic irreversible pulpitis, they are very difficult to block, anesthetize with the help of commonly used local anesthetics. And that's why such teeth, they are called hot teeth. Such teeth are called what? They are called hot teeth. So what is a hot tooth? A hot tooth is a tooth that is having conspicuous amounts of tetrodotoxin resistant sodium channels. And what are they? They are the subtypes 8 and 9. This is the pathophysiology which happens in teeth with symptomatic irreversible pulpitis. Now these sodium channels, okay, they are sensitized by what? Voltage gated sodium channel subtypes 8 and 9, which are resistant to what? Local anesthetics. They are sensitized by prostaglandins. What are prostaglandins? Prostaglandins are the chemicals released in the inflamed tissue. So wherever there is inflammation in the body, there would be release of prostaglandins. And what these prostaglandins would do, there's a case of pulpal inflammation, irreversible pulpitis. Due to inflammation of the pulp, there would be release of local prostaglandins into the pulpal tissue. And these prostaglandins would sensitize the voltage gated sodium channels subtypes 8 and 9. If something becomes sensitive, it would respond at a low threshold. It would respond vehemently. So what happens? They fire at low stimulus. This leads to spontaneous pain. So why a patient with symptomatic irreversible pulpitis experiences spontaneous pain? Due to inflammation that causes sensitization of tetrodotoxin resistant sodium channels, which fire at subthreshold level. A regular stimulus which is not causing any pain in a normal healthy pulp would be causing pain in a sensitized irreversible pulpitis tooth. And that is the basic pathophysiology that happens. And that is why the local anesthetics are quite difficult to attain pulpal anesthesia in teeth with symptomatic irreversible pulpitis. Okay. Another action of local anesthetics. One action is anesthesia. How the anesthesia is attained, we have seen, is on pain control. Anesthesia and analgesia are two different things. Okay. A tooth or a tissue that is anesthetized is numb to all the sensations, that is pain, temperature, touch, proprioception, skeletal muscle tone, all would be gone. Simply analgesia means only pain would be gone. So they produce analgesia. Local anesthetics also produce some degree of analgesia apart from anesthesia. And this analgesic action is through G protein couple receptors, GPCRs, on nerve fibers. What is GPCR stands for? GPCR stands for G protein coupled receptors. On the nerve fibers, there are two categories of G protein coupled receptors. They are represented as alpha I and alpha Q subtypes of G protein coupled receptors. What I am trying to explain? I am explaining the pathophysiology of action of local anesthetics in two different modes. One is the anesthesia, another is analgesia. Anesthesia means blockage of all type of sensations, pain, temperature, touch, proprioception. Analgesia means only pain control would be there. Anesthesia is through the voltage gated sodium channels, and analgesia is through the G protein coupled receptors. There are two subcategories of G protein coupled receptors, alpha I and alpha Q. The local anesthetics, they potentiate the alpha I subtypes and they inhibit the alpha Q subtypes, and this produces analgesia. Only analgesia, no anesthesia. There would be touch sensation, there would be proprioception, there would be skeletal muscle tone, there would be temperature. Only pain would be relieved if the local anesthetic is acting on the G protein coupled receptors. So this is how the local anesthetics act whenever we administer them. Now, if we classify of local anesthetics, that is based on duration of, I'm not classifying them based upon the chemistry of pharmacology, simply based upon the duration of pulpal anesthesia. They can be of three different types, local anesthetics. Those which are short acting means they provide 30 minutes of pulpal anesthesia. I am talking about pulpal anesthesia. Then they are medium acting. Medium acting, they provide 60 minutes of pulpal anesthesia. And then there are long acting local anesthetics that provide up to 90 minutes of pulpal anesthesia, because we are dealing with the endodontic pain control. So three categories of local anesthetics we can choose from. Medium acting, the most common one that we use is lidocaine or xylocaine. Long acting ones, they are bupivacaine. Common examples, there are other groups also, but these are the common examples based upon the duration of pulpal anesthesia. So the recommended ones are the medium and the long acting ones. Now we would talk about anesthetic techniques. See, we would be doing the procedures either in the maxillary arch or the mandibular arch. So we would be requiring either inferior alveolar nerve block to anesthetize the mandibular teeth, or depending upon the location of the maxillary tooth, it can be either posterior superior alveolar, middle superior alveolar, or anterior superior alveolar nerve blocks, mostly by way of maxillary infiltrations. Okay. So firstly, we'll talk about inferior alveolar nerve block technique. IANB stands for inferior alveolar nerve block. Now this inferior alveolar nerve block, when it is administered properly, okay, today I'm not discussing how it would be what are the anatomical landmarks, etc. That is the subject of your basic science. Today I'm talking about the different clinical aspects of the inferior alveolar nerve block, especially in situations which require pulpal anesthesia. So inferior alveolar nerve block, if it is given properly, the onset of pulpal anesthesia, it takes place in 10 to 15 minutes. So we have to wait for that much of time for the onset to take place. And Suppose we have administered inferior alveolar nerve block. How do we clinically know whether the pulp has been anesthetized or not? Okay. So this testing, clinical testing of anesthesia is done by electric pulp tester. How do we know that the pulp has been sufficiently anesthetized? Two consecutive EPT readings of 80 or more. What is electric pulp tester? It is a scale of current from 0 to 100. So two consecutive electric pulp tester readings of 80 or more without pain to the patient within 15 minutes of administration of inferior alveolar nerve block indicates successful pulpal anesthesia. This is how we clinically test. You must have given inferior alveolar nerve blocks, okay, which are given also for tooth extractions. And how do we check? We just probe the gingiva with the help of a sharp instrument. And if the patient is not feeling pain, if there is lip numbness, we assure that we can safely extract the tooth. But how do we test whether the pulp has been anesthetized or not? For that, we have to use an instrument called electric pulp tester, and there should be two subsequent readings within first 15 minutes of 80 or more level of current, and patient is not feeling pain. We can rest assured that sufficient degree of pulpal anesthesia has been achieved, so too we can proceed with the root canal or whatever we are planning to do. Okay, but lip numbness, positive sign is the first indication. Lip numbness means your inferior alveolar nerve block has been given accurately, but it does not guarantee pulpal anesthesia. On the other hand, if there is no lip numbness to the patient on the side of injection, it assures that the inferior alveolar nerve block has not been successful. So there is a relation that is not reciprocal, means lip numbness indicates pulpal anesthesia, or there may not be pulpal anesthesia, but absence of lip numbness always indicates that there is no pulpal anesthesia. Okay. What would be the duration of pulpal anesthesia with inferior alveolar nerve block? It is usually in the range of 2 to 2.5 hours if it is given correctly. And maximum success of inferior alveolar nerve block is with second molar, and least success, maximum chances of failure, are with central incisor. We would be giving inferior alveolar nerve block on the respective side of the mandible. So most successful chances are with the second molar, least successful with the central incisor. Now, we all know that there is a good probability that inferior alveolar nerve block would not be successful. So there are methods to, or we can say factors related to success of inferior alveolar nerve block. To counteract the occurrence of failure with inferior alveolar nerve block, over the years, numerous methods and alterations in the anesthetic techniques have been done, both in the technique of administration as well as the substance, to increase the success of inferior alveolar nerve block. We'll see what all factors actually affect the success and what factors are of no significant value in affecting the success of inferior alveolar nerve block. So the first factor has been the increased concentration and volume of local anesthetic. Okay. There have been attempts that to increase the concentration or the volume of local anesthetic, but these two factors have no effect on the success of inferior alveolar nerve block. I am talking about the factors that have been used over time, which may or may not affect the success. So increasing the concentration and volume of solution has got no effect on the success of inferior alveolar nerve block. Usually, Another factor that has been considered is the direction of needle bevel. We all know that the injection needles, they are beveled, isn't it? This is the bevel of the injection needle. This direction of the injection needle when we are giving inferior alveolar block can be either toward the bone or away from bone. It can be laterally directed toward the bone while injecting, or it can be medially directed away from the bone. But this direction of needle bevel has got no effect on the success of inferior alveolar nerve block. It is of no clinical significance whether we give it medially or laterally. The bevel direction has no influence on increasing or decreasing the success of inferior alveolar nerve block. Another factor that has been considered is use of carbonated anesthetic solution. Carbonated means just like your carbonated beverages, carbon dioxide is passed through local anesthetics. This carbonated anesthetic solutions, they have got low pH. Over the years, the concept has been that whenever the inflammation of the tissue is there, like pulpitis, the local pH of that tissue would be reduced due to inflammatory mediators. And to increase or enhance the action of local anesthetics, we can reduce the pH of the local anesthetic to match with that of the tissue to increase the success of inferior alveolar nerve block. But using carbonated anesthetic solutions have got no effect on the success of inferior alveolar nerve block. Another factor that has been considered is the rate of injection. Okay. While administering anesthesia, we can either make it slow or fast. Slow means at the rate of normally 1 ml per minute. This rate is defined as slow. 1 ml per minute is quite slow, and fast is anything more than this would be considered fast. Of these factors, slow rate of anesthetic injection positively increases the success rate of inferior alveolar nerve block, okay, as compared to the fast. So during administering inferior alveolar nerve block, if we give it slowly, there are more chances that IANB would be successful as compared to when administering it fast. Another factor that has been considered is use of hyaluronidase. Hyaluronidase. Hyaluronidase is a tissue dissolving enzyme. It is a tissue dissolving enzyme. Interstitial substance is dissolved because of hyaluronidase. And the basic idea has been if we incorporate hyaluronidase or inject hyaluronidase simultaneously with LA, what would happen? That would dissolve the intercellular substance and help in better penetration of LA into the tissues. But even though it dissolves the intercellular substance, the success rate of inferior alveolar nerve block is not affected by presence or absence of inferior alveolar nerve hyaluronidase in the solution. Then another factor has been use of mannitol along with local anesthetic. What is mannitol? Mannitol is hyperosmotic sugar solution. It is hyperosmotic sugar solution. Okay. This hyperosmotic sugar solution or mannitol, it causes transient lysis of perineurium, the outermost covering of the nerve membrane. It is called perineurium. Okay, nerve bundles are arranged, epineurium, perineurium, etc. They are the different layers present in the nerve bundle. Transient lysis of the perineurium occurs due to mannitol, and this causes better LA penetration to the nerve. We are administering local anesthetic close to the inferior alveolar nerve, and this increases the success rate of inferior alveolar nerve block. Okay, so mannitol is advantageous in that it can increase the success of inferior alveolar nerve block. So out of the 6 factors that we have seen commonly used, only 2 factors significantly improve the success of inferior alveolar nerve block. The remaining 4 are of no consequence. Then the second technique is maxillary infiltration. Maxillary infiltration. Most of the time, it is called infiltration because we deposit the local anesthetic in the vicinity of the nerve instead of giving a block injection like for mandible. Because maxilla is a porous bone, the local anesthetic deposited in the local vicinity is likely to diffuse through the porous bone and cause sufficient nerve anesthesia. So maxillary infiltration technique is more commonly used. When it is administered, the duration of pulpal anesthesia. Firstly, we'll talk about the onset. Onset of pulpal anesthesia is 3 to 5 minutes because maxilla is porous. The local anesthetic diffuses rapidly, and within 3 to 5 minutes, we achieve pulpal anesthesia. What about the duration? The duration depends upon the type of teeth that we are using. For anterior teeth, we use a maxillary infiltration and we get about 20 to 30 minutes of pulpal anesthesia that is sufficient to extirpate the pulp. For posterior teeth, we get about 30 to 45 minutes of pulpal anesthesia. So what are the onset and duration? It is all related to pulpal anesthesia. I'm not talking about any other form of anesthesia, soft tissue, gingival tissues, mucosa, etc. No, we are concerned about the pulpal anesthesia. So onset and duration are related to that only. What are the factors to increase the success of maxillary infiltration? Increased volume. See, maxillary infiltration is deposition into the vicinity of the nerve fibers. So increased volume increases the success because more local anesthetic would be available to diffuse into the local area. But increasing the volume do not increase the success rate of inferior alveolar nerve block. Okay. Similarly, slow rate of injection would also increase the success like inferior alveolar nerve block. So the only significant difference is the volume, which has an effect in maxillary infiltration but no effect in mandibular inferior alveolar nerve block. These are the 2 principal techniques which are called the primary techniques for the mandible and the maxilla. At times, even though anesthesia has been given properly, there are signs of pulpal anesthesia. Whenever we start the pulpal procedure, there is pain to the patient and we are not able to accomplish the procedure properly. In such cases, we have to administer supplemental local anesthetic techniques. So the 2 ones are the primary. Now we'll talk about the supplemental local anesthetic techniques. The first form of supplemental local anesthetic technique is called intraosseous injection. As the name indicates, intraosseous, the local anesthetic is injected directly into the bone around the tooth. Intraosseous injection. This intraosseous injection is given on side distal to the tooth. We always give it distal to the tooth. So if this is the tooth, okay, suppose a mandibular first molar, mesial side, distal side, and this is the bone around the tooth, the local anesthetic would be deposited into the bone distal to the tooth. Okay, this is the general norm of location of intraosseous injection. The exception to this rule are the maxillary and mandibular second molars. Whenever we have to give these intraosseous injections in such situations, then the site would be mesial to the tooth. Otherwise, for all groups of teeth, it is distal. Why for second molars, maxillary and mandibular? Because the distal bone is quite hard, both in the mandibular and the maxillary region. So it is better to give on the mesial side so that the bone can be penetrated easily and local anesthetic can be deposited intraosseously. So general rule is on the distal, but for mesial, we follow for second molars. Okay. Whenever this is given as a supplemental injection, remember it is not a primary injection. To increase the success of pulpal anesthesia, it has to be a secondary injection, supplemental injection. Onset of local anesthetic action of pulpal anesthesia is immediate. And duration, when it is given as a supplemental injection, is nearly 1 hour. The duration is nearly 1 hour. But when it is given as a supplemental injection and not the primary injection. Now, what are the different types of commercial devices available for this? For giving intraosseous injections, we have different devices available in the market like Stevie-Dent. Okay. The X-tip system. The third one is comfort control syringe. What I am telling you the examples of the commercial products available for administering local anesthesia directly into the bone. Comfort control syringe. They have got special type of penetrators, sharp penetrators. They can go directly into the bone through the mucosa. Okay. Stabilization system, the X-tip system, the comfort control system. Tuttle numb now. And intraflow. These are some of the commercially available systems. Tuttle numb now is one of the latest ones for administering intraosseous injection TTN. Tuttle numb now. Then the second supplemental technique is intraligamentory injection. Intraligamentory injection. It is abbreviated as IL. Intraligamentory injection is considered to be a type of intraosseous injection only. Although the technique is different, it is considered to be a subtype of intraosseous injection only. As the name indicates, intraligamentory, the local anesthetic is deposited into the parodontal ligament around the tooth to be anesthetized in the PDL around the tooth. Normally it is done with number 27 gauge needles. Okay. So if this is a tooth that needs to be anesthetized, This is the bone around the tooth. Then the needle would be inserted into the PDL and local anesthetic deposited. Here important thing is this bevel direction. The direction of the bevel should be toward the bone and not toward the tooth. The bevel is oriented toward the bone so that the local anesthetic diffuses through the cribriform plate into the cancellous bone around the tooth and anesthetize the local nerve fibers over there. So direction of needle bevel is important over here. It is immaterial for the primary inferior alveolar nerve block technique, but for intraligamentary injection, it should be toward the bone. Okay. The local anesthetic should be injected with firm, or we can say strong, back pressure. Whenever we are injecting it into the PDL, there should be immense back pressure or resistance should be felt. Otherwise, it would not be successful. You must have administered local anesthetic into the palate also. The palatal tissues are very firm. Hardly 1 or 2 drops of the solutions goes whenever we are anesthetizing the greater palatine nerve on the palate of the patient. Similarly, strong back pressure should be felt when we are injecting it into the PDL around the tooth. If it is done properly, the onset of pulpal anesthesia is immediate. No waiting is required, but remember it is a supplemental anesthetic technique. And the duration of pulpal anesthesia that is achieved is nearly about 10 to 20 minutes when it is given as a supplemental technique. Now, various devices are commercially available systems for giving intraligamentary injections. They are the wand system and CCLAD. CCLAD is basically the full abbreviation for computer controlled local anesthetic delivery system. There is a computer controlled device which delivers local anesthetic at a specified rate, duration, and volume into the PDL. So it is a convenient system, CCDLD, and the wand. These are commercially available devices for intraligamentary injection. Intraligamentary injection should not be given in patients with periodontitis. A patient who is already having periodontitis, inflammation of the PDL, destruction of the PDL, intraligamentary injection should not be given because it can cause further damage to the already compromised PDL of the patient. One of the principal contraindications. Then the third supplemental technique is intrapulpal injection. As the name indicates, intrapulpal, directly into the inflamed pulp tissue, we would inject local anesthetic, but this is considered to be the last resort. When all other techniques of LA have failed to give sufficient pulpal anesthesia to carry out the procedure, intraligamentary injection is considered to be the last resort. Why it is last resort? Because we are injecting local anesthetic directly into the inflamed tissue, which is already sensitive. The patient would experience severe pain during the couple of seconds that we administer the anesthesia. So we have to first take the patient into confidence, explain the procedure, and then go for it so that the patient is mentally prepared to bear that pain for the couple of seconds. That's why it is considered to be the last resort. What is actually done? There is a closed pulpitis case with inflamed pulp. Then a pinpoint opening is made into the roof of pulp chamber. Into this pinpoint opening, we wedge the injection needle and inject 1 or 2 drops of solution into it. Strong resistance, very high resistance should be felt during injecting it directly into the pulp. Okay, so it would cause immediate pulpal anesthesia. No more than a couple of drops should be going. If it is going freely, it means the technique is not accurate and you are not able to wedge the needle exactly into the pulp. So with great resistance, if we inject a couple of drops, immediate pulpal anesthesia would be there. And the duration that we attain is nearly 15 to 20 minutes of pulpal anesthesia. 15 to 20 minutes. This 15 to 20 minutes of pulpal anesthesia is sufficient for pulp extubation and going forward with the procedure. So these are the principal techniques of administering local anesthetics in patients, 2 primary ones and 3 supplemental ones. Now in a patient in which we have given inferior alveolar nerve block, there would be lip numbness, numbness of the tongue on the same side, apart from the pulpal anesthesia that we have attained. Now we have completed the procedures in about 1 hour or so, but the patient's soft tissue numbness, like the lip numbness, tongue numbness, would last for nearly 2.5 hours, or maybe more at times. So it is very uncomfortable for the patient who has undergone inferior alveolar nerve block for a particular procedure to have anesthesia of also the soft tissues like lip, etc., for a couple of hours after the procedure. The patient cannot engage in normal conversation. The patient is asked to refrain from eating and drinking, especially the hot liquid and hot food, because there can be pain. So it is quite uncomfortable for the patient. So after inferior alveolar nerve block, the soft tissue anesthesia, it can be reversed early. It can be reversed early by soft tissue reversal agent. What is that? That is commercially called Oraverse. It is commercially called Oraverse. Oraverse basically it is a cartridge containing chemical called phentolamine mesylate. Okay. Nearly about 2.5 hours, we'll ask the patient to have the hot food or liquid so that there are no chances of burn to the oral soft tissues. So there is an injection called Oraverse commercially available that is consisting of phentolamine mesylate zero point 0.4 milligrams in a 1.7 ml cartridge. After completion of the pulpal procedure, if we administer Oraverse in the same location as inferior alveolar nerve block, there would be reversal of soft tissue anesthesia. The lip numbness, the tongue numbness would reverse by phentolamine mesylate that is called Oraverse. So it can be quite convenient for the patient to resume the routine activities. The patient can engage in social dues like speaking, etc. So these are some of the techniques and related procedures of local anesthetics. Now, whenever local anesthesia is given to the patient, the procedure is done either in single visit or whenever we recall the patient. But for post-operative pain management, there is drugs which are used for post-operative pain management. So basically endodontic pain control relies upon three Ds. What D stands for? Firstly, there should be an accurate diagnosis. The second D, firstly, we have to accurately diagnose the clinical situation. Then, definitive treatment, like doing root canal, etc. And the third D of endodontic pain control includes the use of drugs, different types of pharmacologic agents that can be given orally or parenterally to the patient to manage the pain. What are the drugs that are given? Related to the pain management, the most commonly used drugs are non-steroidal anti-inflammatory drugs for endodontic pain control, preoperatively or postoperatively. There was a big study conducted called Oxford Ivy League study to find out the efficacy of different non-steroidal anti-inflammatory drugs for endodontic pain control. And according to that study, was concluded that the most effective for pain control related to pulpal pain is ibuprofen in high doses of about 600 to 800 milligrams per day. That is QID, 4 times per day, 600 to 800 milligrams. The second drug, which has been found to be potent, is ketorolac tromethamine, which is usually given 10 milligram 3 times a day. Ketorolac, tromethamine, ketorol DT, all must be aware with that. And the third drug is acetaminophen. These two are non-steroidal anti-inflammatory drug, and this is a paracetamol. High doses, that is 1000 milligram per day. 1000 milligram per day. These are the three drugs which have been found to be most potent in managing the endodontic pain or pain associated with pulpitis. Some local action. It is an age-old therapy with local action. What drugs can be used? That is a clove oil or eugenol. Age-old remedy for the dental pain has been clove oil or eugenol, but it provides only a local relief. It cannot be ingested. It is applied onto the tooth. It basically causes odontoallodynia. It is inhibited by the action of the clove oil or eugenol. Okay. But basically, if we are talking about some ingestible drugs, these are the drugs which are given a combination. For the drugs, the most important thing is that there should be a flexible plan. Flexible plan means we can use a combination of drugs. Combination of drugs depending upon the severity of endodontic pain, mild, moderate, and severe. 3 categories of endodontic pain can be there to the patient. If the patient is reporting mild pain, simply 600 to 800 milligrams 200 to 400 milligrams of ibuprofen is sufficient. If the patient is reporting with moderate pain, we have to make it a flexible prescription, modify the dosage of the drug from 200 to 400 to 600 to 800 milligrams of ibuprofen. If patient is reporting with severe pain, then we can combine 600 to 800 milligrams of ibuprofen plus 60 milligrams of codeine, which is a opiate group of analgesic. Non-steroidal is combined with opiate group of analgesic. This is known as flexible prescription plan. And secondly, important thing, drugs should be given by the clock. Okay. By the clock means the patient has to take the drugs routinely at said interval, specified interval according to the choice of drug, and not SOS, and not as and when needed. Because if the pain onsets, it would be difficult for the oral drugs to take control of the pain. A lot of time would be required for them to act. So it is better that onset or the episode of pain should be inhibited before onset only. For that, the drugs should be given by the clock. Okay. We have previously talked about tetrodotoxin sensitive and resistant sodium channels. A patient with symptomatic irreversible pulpitis who is having TTXR sodium channels cannot be anesthetized with LA because local anesthetics are not acting on it. Also, we know that due to liberation of prostaglandins, these sodium channels are further sensitized and they keep firing. The patient experiences pain at suboptimal stimulus. So to prevent that, pre-medication with non-steroidal anti-inflammatory drugs is beneficial in management of hot teeth. Why? Because these non-steroidal anti-inflammatory drugs, they would inhibit prostaglandins, isn't it? The prostaglandins which are present as inflammatory mediators. So when the prostaglandins are inhibited, the sensitization of voltage gated sodium channels is reduced and they are blocked more predictably by local anesthetics. This is the way we manage hot teeth. We can, in a way, indirectly increase the efficacy of local anesthetics in such cases. Okay. There is a new class of drugs, non-steroidal anti-inflammatory drugs, okay, which are called CNODs or nonacetes. CNODs or nonacetes. CNOD stands for COX inhibiting non-steroidal odontogenic drugs. Okay, COX inhibiting. Nitric oxide donator. This is a new class of non-steroidal anti-inflammatory drugs, means they release nitric oxide. And from the basics of pharmacology, you must be knowing that nitric oxide is basically a vasodilator. So it increases local blood flow. And once the local blood flow is increased, there's increased action of non-steroidal anti-inflammatory drugs, and there is decreased chances of gastric irritation. One of the most common side effects that the patient reports with too much of analgesic is they complain of gastritis, burning in the stomach. So when the local blood flow is increased, the drug would diffuse fastly, acting fastly, and it would be locally eliminated fastly as compared to the conventional non-steroidal anti-inflammatory drugs. These class of drugs are called nitric oxide donating non-steroidal anti-inflammatory drugs. They are in the developmental stages, not yet approved by the Food and Drug Administration in the USA, but may be available in the near future. Okay. So these are the different aspects of endodontic pain control, from local anesthetics to their techniques to their management with the help of drugs. This is all about for today's session. I hope it has been comprehensive enough for you all. Thank you very much for being with me. See you next month with another exciting topic related to the subject of Conza Endo. Till then, happy reading. Take care, everyone. Good night.